Can cosmetic filler migration be prevented?
Recently, there has been a growing concern about filler migration. This particular concern is also in addition to the usual questions that come up about filler type, filler longevity, and the desire for a natural appearance. So why has filler migration become more of a concern? I'll discuss what filler migration means and how I take steps to reduce the risk of it happening, and what options you can consider if you happen to experience this issue. To begin with, when I talk about fillers, I generally focus on the hyaluronic acid fillers. Hyaluronic acid fillers such as Juvederm and Restylane are very popular and have numerous applications for facial enhancement. These fillers, depending on type and anatomic location of placement, can last from 6 months to up to 2 years. Since hyaluronic acid naturally exists in the body, these fillers are metabolized without any long-term issues. Should there be any issues, hyaluronic acid fillers can be dissolved with an enzyme called hyaluronidase. This is in contrast to permanent or semi-permanent fillers, which cannot be dissolved. As a specialist, I have surgically removed these filler materials placed by other doctors. So what does migration actually mean? Migration means that some of the material placed in a specific area has moved to another area, usually an adjacent area. For example, filler placed into the lips moving outward, away from the lip border. Patients will often ask if the filler can migrate far away from the area where the material was placed. For example, can under-eye filler move all the way to the jawline? This is unlikely. In my opinion, filler migration has become a relevant topic because of a combination of factors. The first factor is the practitioner. It was not that long ago that the placement of injectable fillers was almost exclusively being performed by doctors with formal residency and fellowship training in aesthetic procedure-focused fields, such as cosmetic surgery, facial plastic surgery, or oculofacial plastic surgery. In fact, dermatologists speaking at conferences would be openly critical of doctors in other specialties performing injectables at all. Yet, these same dermatologists employed nurse injectors and physician's assistants in their practices to perform these procedures essentially unsupervised. Due to financial pressures from low insurance reimbursements for necessary medical care, doctors from all specialties are taking weekend courses to learn how to practice aesthetics. A significant number of non-physicians, such as nurses and physician's assistants, are also performing injectable fillers. This means that when there is such a wide range of expertise, it makes sense why all kinds of filler-related issues occur. Let's look at the products. The major companies like Allergan and Galderma have done a very good job at developing products with different physical characteristics for practitioners in order to provide better results for their patients. At the same time, it appears that many practitioners rely too much on some of these subtypes of fillers to maintain their shape in a way that the filler material just cannot. For example, a thicker hyaluronic acid filler can be used for cheek enhancement. Typically, this filler is placed just below the skin and the patient can look good in the exam room. Subsequently, the patient experiences a change in the shape from where they started with as the filler gets compressed by normal facial movements, like smiling. This compression results in filler migrating in an outward direction. The same patient then returns to the injector and gets additional filler placed, and the cycle continues. Over the course of months and years, these fillers can accumulate and migrate further, resulting in an unnatural and somewhat doughy appearance. Consumers are bombarded by marketing for injectable fillers. The companies that promote their fillers and the practitioners, particularly the lower tier, mid-level providers and physicians who are not trained in cosmetic surgery, often promote low-cost fillers. Consumers are led to believe that the product is responsible for the results. So an inquiry can sound like, how much do you charge for product A? This is absurd, since the product does not control the hand of the practitioner. It's the skill of the practitioner, which is based on training, expertise, and experience, that determines results. A skilled practitioner can use a range of fillers to achieve quality results. The take-home message here is that technique matters, and it's the practitioner is far more important than any specific hyaluronic acid product. During a consultation, when a patient asks about the risk of migration, I explain that migration is not really an issue for my patients because of my approach. For example, common concerns for patients include loss of volume and projection in the cheekbones, chin, jaw angles, and the under eye area. These areas are often deficient at the bone level. Conventional filler placement is just below the skin level. As an oculofacial plastic surgeon, I've performed surgeries such as facial implant placement and bone reconstruction. This experience provided me with a strong foundation when I was trained in performing structural volumizing, where hyaluronic acid fillers are placed at the deeper bone level, resulting in better proportions and more youthful definition, such that the patient can at times appear as if they've undergone a surgical facelift. In my experience, I've yet to have any patient experience filler migration when I use this technique. I often see patients who've had under-eye filler that migrated to deeper areas under the eyes. Much of the time, they've had repeated injections of hyaluronidase by their injector without any improvement. As an oculoplastic surgeon, I first trained in ophthalmic surgery. So I've had extensive experience injecting hyaluronidase behind the eye as part of the anesthetic procedure we used to do before cataract surgery. I place hyaluronidase into this space, and these patients typically look much better afterwards. When you have any disfigurement or undesirable outcome related to migration, it makes sense to dissolve the hyaluronic acid filler with hyaluronidase and then determine the appropriate next step. There are, of course, areas such as the lips where the filler has to be placed into the soft tissue. My approach is to work with the patient's anatomy and conservatively place filler using blunt-tipped cannulas. I'm able to minimize the risks of bruising, lumpiness, and filler migration when I use this method. As a specialist with decades of experience, I've been called upon to help patients who've had filler-related complications, as well as having unsatisfactory results. This doesn't mean that anyone is immune to having challenges or complications. There is risk in any endeavor. The best strategy is to minimize risk. Unfortunately, aggressive marketing and people like unprofessional doctors who engage in interspecialty disparagement, consumers are often confused and unable to make properly informed decisions. What should be foremost in your mind is expertise and experience. Hospitals, for example, will proudly promote services such as open heart surgery based on having doctors with high levels of expertise and experience so patients feel confident about their chances of having successful outcomes. When mid-levels and moonlighting doctors have complications, they turn to the doctors with the highest level of expertise and experience to help their patients. The practitioner is far more important than the injectable product for a successful filler procedure. I hope you found this information from my experience helpful. If you're interested in recommendations for your individual situation, you may contact us through our websites or call our offices to schedule a consultation. Thank you.